Welcome back to the MedEdit podcast, your ultimate resource for evidence-based medical education.
And the podcast where two board-certified physicians interview specialists to tackle the myths and trends you see every day on your social media feed.
Today, we're diving into one of the most important and most misunderstood topics in medicine, and that's heart health. Cardiovascular disease is the #1 cause of death in the United States, responsible for 1 in 5 deaths. So today we're taking time to talk all things prevention, social media trends, and how to separate real cardiovascular science from clickbait wellness advice. Toss endless online searching to the curb. Let us edit out the noise and bring you medicine without misinformation. Welcome to the MedEdit podcast. So on the podcast today, Dr. Kelly Ratheal is our guest. She is a triple board certified physician. She has a board certification in internal medicine, cardiology, but not just that. She also has a board certification in lipidology, which is actually the advanced study of cardiovascular things like cholesterol. She's about the specialized training in prevention and cardio-metabolic medicine. She focuses on helping patients identify and reduce their own cardiovascular risk through a holistic, evidence-based approach. She does love to integrate lifestyle, genetics, and advanced imaging together to create your most optimum health. Dr. Ratheal earned her medical degree from Texas Tech University Health Sciences Center School of Medicine and completed her internal medicine residency there, as well as her cardiology fellowship. Her areas of expertise, as we said, include really that prevention, that preventative cardiology, health, lipid management, which is cholesterol, and focusing on metabolic syndrome. With nearly half of all U.S. adults, which is about 48%, having some form of cardiovascular disease or a major risk factor, this is the perfect opportunity to dig further into this topic. We are so thrilled to have her on the podcast today. Welcome, Dr. Ratheal.
Thanks for having me, guys. I appreciate the opportunity to be here and help spread some knowledge about prevention.
Absolutely. And let's start with some of that knowledge. Let's start with the basics. For those who may not be familiar, what exactly is preventative cardiology and how's that really different from a traditional kind of cardiology practice that our listeners may be used to?
Preventive cardiology is now, I would say, coming into its own as a subspecialty. It wasn't previously recognized as its own entity. However, now there are several recognized fellowships in the country for prevention. Docs might get down this path either through internal medicine, endocrinology, cardiology, and then spend an extra year with a focus on prevention, meaning we're learning how to assess risk factors, and especially those aside from the traditional ones that I think most people understand, like sedentary lifestyle, family history, smoking, high cholesterol. There are many other pieces of the puzzle in terms of having a detailed individual risk assessment, and so sitting with a specialist who has practiced in that area allows you to have a more specific assessment for yourself so that you can hone in on what really might be the biggest bang for your buck in terms of medication and lifestyle and start at an earlier age. I think that's one of the things that is finally kind of getting into people's heads is that if we start earlier in life, we have more time with those risk factors optimized, and that prevents disease more effectively.
So I think in full transparency here, I've known Dr. Ratheal since our days as, interns back, working the ICU days where we bonded, but also she's my cardiologist because really more for like preventative measures, kind of looking at, family history and genetics. I think she does some really cool things that we'll talk about today, but it is fun because it isn't necessarily always the standard things that maybe your cardiologist who might be looking at it from the lens of I'm trying to solve or fix a problem that's already there. Her whole life goal is just to prevent the problem from ever coming, to surface, even if you're doing everything you possibly can do. And it's just the genetics that you can't get around. So it's really exciting to be able to talk to you about this today.
Thanks.
So back to heart disease. So heart disease does remain the #1 cause of death, like we said, in the United States, but also especially in women. Everyone always thinks about, breast cancer. There's Breast Cancer Awareness Month. We really don't do a good job about focusing on like heart disease and heart disease, awareness month. In fact, heart disease kills more women than all forms of cancer combined, yet only 56% of women recognize it as their leading health threat. So Dr. Ratheal, why do you personally think that we continue to struggle with prevention, even though we know so much more now about heart disease than we did decades ago?
I think when the women realize that this is a threat to them, just like it is to men, then the whole family will learn about prevention. I think
it starts with the women.
We are last when it comes to taking care of ourselves. So I think that still plays a cultural role in why women seek cardiovascular care less frequently than men. They also present in a little bit different way, and I think a lot of women are catching on to that. But as soon as moms, and I mean our age and younger, realize that what behaviors their children are having in terms of lifestyle, and how they're raising them plays not only a role in their physique and ability to exercise and find a mate, if you will, but or likelihood of diabetes, but also their likelihood of forming cardiovascular disease. It matters that early in life. And I think if you tell any mom, hey, there's something you can do while your kiddo is still small and under your roof to help them have a long and happy, healthy life, then they're gonna want to learn about that and teach their kids. And so I think that there's a bit of a lag, like with every other, advancement in medicine, but I think culturally we're starting to recognize that this starts very early, or it can, and we can be successful that way. So I think women's heart health will come with recognizing it as a ubiquitous human disease process. If we live long enough, we have plaque that becomes visible. And so we just want to know when is the most appropriate time in each individual to use tools in addition to lifestyle.
That's great.
Yeah, and that's like you mentioned, with more awareness, it's probably where we hear more things on social media about, terms being used like cardio-metabolic health and things like that. It's kind of all over social media as well. Can you kind of explain what that term actually means and why it's important for all of us?
So cardio-metabolic health is easier to say than cardio kidney metabolic health. There is a new diagnosis category called CKM that is, I would say, at the front of every lipid cardiometabolic prevention conference at this time. We have more specific ways of quantifying what stage are we in, meaning how is our metabolic health affecting our organs. So we'll back up for a second. Metabolic health is, I explain it to patients as like, how does the engine run? Is it efficient? Are we processing the fuel that we put in well, or are we having a lot of, gas emissions and engine crud? And, are we able to exert ourselves effectively? Like, how's your 0 to 60? And how is our body composition? Is hard to make an analogy with cars, but body composition is in there too. So are we maintaining our muscle mass appropriately? Are we accumulating a lot of visceral fat or fat around your organs? So metabolic health is a kind of a catch-all term for how efficiently is the system running. And that plays a really large role in our likelihood of developing chronic disease. So if we manage with lifestyle choices our metabolic health and maintain it, then we reduce our chronic disease risk astronomically. And then there are still other tools like medications that we'll talk about that can help optimize risk. And in some people, they're very important even at really young ages. But metabolic health is what we have control over with lifestyle, I would say. And then when it goes south, it can negatively affect our heart, our kidneys, our liver, our brain. And so that's where this CKM axis comes from. But I'm glad to see that we're quantifying it more specifically and really staging it almost like cancer, because there is a progression of this disease process if we don't get those risk factors in check.
I think that's great, especially for me in my practice. I think we've always bonded on the prevention side of it. And I see in primary care a lot of younger individuals, and they're just starting to see issues, with their lipids, so like their cholesterol, or starting to see high blood pressure, and they're still only in their like mid-20s, right? They've got sleep apnea, or they've got liver enzymes that are starting to creep out. All these little things that we're like, what you're doing now in your 20s determines how you're going to live your life in your 30s and your 40s. And if you make it past your 40s, like, all these big complications. Right. And so that's really like the biggest look at it is what can we do now to help? Or even if you are in your 40s and you think, hey, I'm young, I eat okay, I don't need to worry about heart disease. So when you said that the younger generations need to listen to this, but when specifically should we start paying attention to cardiovascular risk factors? And if they're coming to someone like maybe their primary care physician, that's their first into having these conversations, what should they be asking to look at?
So let's say family history is unremarkable for diabetes, cardiovascular disease, everybody's pretty healthy. Then children, really from a screening standpoint, I think our primary care does a great job at talking about in little kiddos, what are we eating? Are we having healthy bedtime routines? How's our body composition? Are we overweight? What do our vitals look like? There's not a lot of blood work done, and so comments on blood sugar, I think, are less available, but knowing certainly if there's family risk, what's their blood sugar like is important. From a cholesterol standpoint, every child should be screened, so basic lipid panel between the ages of 7 and 11, and then again after puberty, so like 15 to 17 onward. Puberty actually can falsely lower lipid levels, and so it can downgrade your risk assessment a little bit, maybe inappropriately. Families that have high cholesterol or coronary disease or other identified cardiovascular risk factors, those kiddos might warrant screening for cholesterol even as early as 2 years old.
Wow.
And so that varies a little bit. Those are your FH patients or familial hypercholesterolemia patients. And sometimes, if you're screening a kiddo, let's say they're 7 and their LDL is above 160, you might well have found an FH patient, and those parents should be screened because sometimes they're our age and they have no idea because they haven't been screened. And so there's a little bit of this kind of retrograde cascade screening that can happen. And so using the universal lipid screening for children is important, and I think it's underutilized in my experience, I guess, because I get a whole lot of adults who are even, let's say, in their 20s when they come to see me because their family history is bad, who have never had a lipid panel that they know of. Now, it doesn't mean their mom doesn't have it and they just don't know, but there's a lot of, I've never had this done, and it could even be into their 30s and 40s. And so I would say, as an adult, if you're 20 and you're done with high school and you're a grown up, go have your risk assessed. So just have a once over.
So if you're a kid, or sorry, I just want to look back on that one. But if you have a kid that ends up having elevated, cholesterol panel, their lipid panel, what are you counseling them on? Is it just really doubling down on those lifestyle interventions? Because I know some people may get afraid and say, well, I don't want them checked because they're going to put them on medicine or something. Like, what do we look at there?
So in kids who have, I would use LDL of 160 as your cutoff. And so if they have an LDL under 160, and LDL is low density lipoprotein, I think most people recognize that as bad cholesterol. That's an oversimplification, but it is the one that is most recognized as lending itself towards creating plaque burden, right, or atherosclerosis as we age. So if LDL is under 160 in a child, but over about 70, I would say you should think, that's a little high, right? And we should talk about dietary changes and how can we optimize metabolic health. I would really ask those questions of the parents, like, what does your lipid panel look like? What is your history? They may be too young to have disease, and they may not realize that they should be being treated. And so I would say those cases are really focused on lifestyle, but I would bring attention to the parents so that they can maybe start learning about this topic and maybe start with themselves, because it might be that they go and have a risk assessment and the doc's like, yeah, we should treat this. So, but if you find kiddos with an LDL over 160, they might really well should be on lipid lowering medication even at that age. I would still give, a 6 or 12-month trial of lifestyle with multiple lipid panels in there, especially if they have a really poor diet. If they're eating fast food a lot of fried foods, a lot of highly processed foods, then I would see, what you can get out of that. But if their diet's reasonable and they're over 160, they should really, family history needs to be assessed and parents need to be aware, and that child should probably be treated.
Okay, so I feel like this is a good place to ask you, but with all the things we hear about cholesterol, I have patients who come in and they'll say, well, my LDL is bad, but my HDL is good, and that evens out, right? I'm sure you hear that one a lot. Or sometimes we're getting asked about more and more about the appropriate use of the lipoprotein A testing. Can you expand a little bit on specifically the cholesterol panel and what they mean? And so that when patients, hopefully patients get a good explanation from their provider when it gets ordered, but some of them don't, or some of them get it through their health screenings, like through their work or something, and then no one really explains it fully to them.
So let's start with lipoprotein little a, or LP little a. This is, I think, the best, easiest way to picture it is a version of LDL. LDL's evil twin, if you will. It's structurally very similar to LDL, but has a little tail on it, this apolipoprotein A, that gives it its potency in terms of risk. And so it has not only atherogenic or plaque-forming risk, but inflammatory risk, meaning we can have not just plaque rupture, but thrombosis or clot formation, specifically in the arterial side. So childhood strokes, if we're talking about the pediatric range, this has been correlated with childhood strokes that have no known etiology. And in grown-ups, it significantly increases, so about six-fold your risk of cardiovascular disease, heart attack and stroke specifically. So not just, oh, I've made plaque and narrowed my vessels, but I've had a plaque rupture, because it's very good at creating soft or non-calcified plaque, which is more prone to inflammation and rupture. And it also can prematurely calcify the aortic valve and lead to severe aortic stenosis a decade or two earlier than we might anticipate seeing otherwise. It needs to be checked in everyone once in their life. This is the expert consensus on LP little a now. For a little while, there was kind of screen the high-risk families, and now it's so easy and affordable to do. Everyone should be screened once above the age of 5. And, and this could be something where if it's the pediatrician or PCP is uncomfortable doing it, then, when you do your screening at 20, because everybody's going to come and have their risk assessed, then that would be part of it, ideally, so that at a fairly young age whether you have that risk factor. The reason this is important is because it's not modifiable with lifestyle.
Okay.
So diet, exercise, weight loss, sleep, stress. We do find that it fluxes a little bit if we're having, sepsis or kidney injury or acute liver failure or things that alter maybe the metabolism of that lipoprotein, but we can't consistently manipulate it and lower it with lifestyle changes, nor medication at this point.
So I feel like in my setting, that would be something like if I check their LDL and it's elevated and they're doing everything else right. They're working on the diet, exercise, everything else. And then I add a lipoprotein A and it does come back also elevated. Then we can say, that's great. Keep working on all the lifestyle stuff, but we're probably going to need medication. Is that kind of the appropriate use for that?
Yeah, the reason, if they're already hesitant to use medication to treat their LDL, it sort of supports your wanting to, based on what already exists in their risk profile that they are not connecting with. Because since we can't lower LP little a with medication currently, we will have drugs for it very soon, but we can't currently. There's nothing labeled for that, let's say. Then we want to counterbalance that risk with lowering or optimizing the risk factors that we can change. And we can really, really easily manipulate and very effectively manipulate LDL and ApoB. So those two numbers go together. We'll talk about that a little bit. But we want to optimize those. We want to optimize blood pressure. We want to optimize metabolic health, because those things we do have really big levers to pull, and that counterbalances the risk that comes with lipoprotein little a.
That's good. I think that answers my question, because I was always wondering how to incorporate that a little bit better.
I don't know. My easiest example, I think, is like, he's a boy and I'm a girl. And if all of a sudden I was like, oh, well, now you're a boy and you have all the risk that comes with it, I can't change it. What do you want to do about that? Because men have more cardiovascular risk than women, at least a little earlier than women. And so it's not modifiable at this point in life. And if I just said, okay, well, what if this were the scenario? Sometimes it helps people understand, like, this inherently lends more risk. It's not like,
right.
But it's on the order of smoking, like it's a legitimate risk factor if it's elevated. It shouldn't be, scoffed at. I think I've seen a lot of nasty outcomes with high LP little a and fairly normal LDL. And so this is not, even in and of itself, it can create quite nasty atherosclerosis with clinical disease at a premature age. So you don't have to have a high LDL to have a high LP little a.
Yeah, great question. And I think that overall we see a lot of stuff online about, cardioprotective things of what you can do that may help. And some of sometimes a little far-fetched. Sometimes they fluctuate with the winds, it seems like. Some of these things I feel like have changed multiple times, even in our lifetime. But we're going to talk about some of them in one of our favorite segments, which is fact or miss for misinformation. And we'll address some of these issues and some of these claims.
So we'll read a few popular heart health claims we've seen on social media circulating recently, and you just tell us fact or miss. So Carrie will start with it.
Okay. Number 1, you can detox your arteries.
Miss.
What about red wine is good for your heart?
Uh-oh.
Miss.
What about you can reverse plaque with supplements?
Miss.
What about women don't need to worry about heart disease until menopause?
Also miss.
Yeah. All right. And cholesterol just doesn't really matter anymore.
Definitely a miss.
I think we just expanded on that one.
Yeah, exactly.
Yeah.
I love it.
Rewind.
Yeah.
a little
Rewind
bit.
and re-listen. It's actually gone the opposite. We care
Right.
a lot more than we used to. And then the last one, what about too much cardio is bad for your heart? I have heard this one recently from some patients and I was like, what? Tell me
Miss.
more. Yeah. Is there an explanation more to that one?
I think that gets into the weeds a little bit. Too much cardio is probably physically impossible for most normal humans to accomplish.
Right.
Yeah,
Yeah.
that makes sense.
I'll say
If
too
we're
much
talking
cardio.
about like you're at the elite,
Yeah.
long distance, 100-kilometer run athlete level,
yeah.
I think we can get into, are we overworking?
Yeah.
Right?
Mhm.
Is there some negative effect there? But I would say overall, that's probably a miss.
I can say that too much cardio is bad for your gut. So you can
There-
throw that out there. Increase your risk of colon cancer.
Too much cardio could increase your colon cancer risk?
Yeah.
No
and
way.
ultra marathoners, there's a new study
Oh,
that came out
yeah,
that they may
okay.
be an increased
They
risk
were-
for colon cancer.
Yeah,
So-
but
Back in that range.
yeah,
In
back
the
in that
ultra,
range.
like,
Yeah.
I mean,
same
so
group,
most-
same group you're talking about.
Yeah.
Most humans
No,
are
yeah,
not going to
right,
run
right.
that much.
Which is,
Yeah.
and that's what we always talk about, like on the social media thing, right?
Yeah.
Something will take like a snippet of maybe something that has some basis
Right.
in
Sure.
science, and
Yeah.
then they just took it the whole opposite way. Like, okay, like cholesterol
Mhm.
doesn't matter. Okay, well,
Yeah.
things like that. You're like, well, it does matter, and specifically this way, or cardio
Yeah.
running it hurts your heart. Okay,
99% of us won't achieve that level.
Yeah.
Let's put it that way.
Yeah.
Or even more.
Right. You could try.
You could try. Yeah, exactly.
I don't know if I want to be. I definitely don't want to try the ultra. I thought that sounds
No.
horrible,
It'll
but-
increase your risk of colon cancer. Don't do it.
Yeah, no, that's
Right,
why I'm not going to do it.
Well, love it. That's why we do this game. There's a lot of easy, misinformation out there that people kind of clickbait, those type of things. So
Mhm.
thank you for helping us clear that up.
So let's move on to talk about the connection between the heart and the metabolism a little more, though. So only 6.8% of the United States adults apparently meet all 5 markers of optimal metabolic health, which technically, I guess, come into things like the normal waist circumference, blood pressure, having good blood sugars, your triglycerides, and your good cholesterol, I guess your HDL cholesterol. This is kind of what I guess the CDC says. But how do all the other things outside of here, the insulin resistance, inflammation, metabolic syndrome, how does it all come together to contribute to heart disease?
So metabolic syndrome is defined by 3 or more of those 5 criteria that you listed just a second ago. So waist circumference, blood pressure, blood sugar, triglycerides, and HDL are your components. There are a few different ways to measure the blood sugar side of things, and we can get down that rabbit hole a little bit if you'd like. But 3 or more abnormal numbers in that set of 5 constitutes metabolic syndrome. And metabolic syndrome originated as it's a clinical syndrome. So syndromes are a constellation of abnormalities that we see that causes a phenotype or a physical outcome or disease process. And so when we recognized that this was the constellation that patients were accumulating that led to diabetes, heart disease, stroke, even cancer, then we named it metabolic syndrome. And we've been studying to see how these correlate with those chronic disease outcomes for a long time now. This is a really well understood topic, I would say, or a well investigated topic. We have always had more to learn, but it is important. And I tell so many of my patients who come for cardiometabolic, if they come specifically for cardiometabolic assessment and risk assessment, what are these numbers and why are they important? Because these are the numbers that you have the power to change with lifestyle. So I don't want to start medicine, I just want to do it naturally. This is all you, man. I don't have magical drugs to make these normal. We're getting there, but there's nothing that replaces a healthy lifestyle. And so these are numbers that if you keep them normal, so if when you're 20 and you come for your risk assessment, if they're normal, we want to keep them normal. And if they're not, then we want to work on returning them to normal as soon as we can because they play a large role in our risk over a life. Insulin resistance is on the spectrum of this abnormal blood sugar, right? So traditionally in metabolic syndrome definition, it was either fasting glucose over 100 or A1C that is abnormal. That's a little more vague. I would call an A1C of 5.7 abnormal. It used to be that we split hairs and there was semantics about 5.7 to 6 is insulin resistance and 6 to 6.4 is pre-diabetes and 6.5 and above is it's all the same thing. Okay. So, and if it's abnormal, how abnormal is it can be important to quantify because it may dictate what type of medications we want to use or how aggressive we are with our interventions, but it is abnormal. And if it's abnormal, it's not optimized, and therefore our risk has some improvement that could be had. So other ways of measuring insulin resistance, and I think a little bit more accurately than solely with fasting glucose or A1C, are looking at fasting insulin and C-peptide. And the gold standard is an oral glucose tolerance test. So ladies, you remember the orange sugary thing that you drink during pregnancy. Ideally, if we do an OGGT, we would do that alongside with not just glucose levels, but insulin levels or C-peptide levels at each interval to demonstrate not only your glucose response, but your insulin excretion with that load of glucose. And that gives us insight into how efficient is the engine running, right? So we talked about that earlier. Inflammation is a very broad term. It's a very popular term right now. You can't see it, just right here. If I say I have so much inflammation, I mean, maybe dermatologists can see it, but you can't, I don't know. I think that people say, I know I have so much inflammation, and we can look and all of their lab markers are normal in every way that we know how to measure inflammation, even if it's vague. And so I think there's a little generalized misunderstanding about this term, but the way that I explain it to patients is there's an inflammation side and a atherogenic lipoprotein side. So if we go back to LDL, LP(a), okay. Those two columns are really the levers that we want to pull or manipulate to optimize risk. And we need to do both. The inflammation column is really driven and manipulated by lifestyle, and the atherogenic lipoprotein column is not so easily manipulated with lifestyle, a little, but usually if we want to treat it, we're going to use medication because it's much more effective. I think that's beyond the scope of this talk, but inflammation as it pertains to metabolic health often comes from visceral fat. And so as we accumulate adipose tissue, we do it under the skin first, and then eventually we kind of overflow this capacity to store fat under the skin, and it gets put around our organs or in the viscera. And that actually is inflammatory in and of itself. So we see that inflammatory markers rise when we have more visceral fat. The fat itself can be toxic. So this is called adipose toxicity, and it creates damage to our arteries over time, which is part of how it contributes to cardiovascular disease. And so the inflammation from the metabolic health standpoint can be greatly mitigated by reduction of visceral fat. And that comes with glucose control and changing our body composition, which means adding muscle. And people don't like to add muscle up front because it makes their number on the scale go up. But if we do this, then the visceral fat goes down and things level out. And usually aesthetically, people are very pleased. But it takes a lot of work. But this is how I would say that and sleep. We haven't touched on sleep, but that's a very important topic. I think that's, we can leave that for another day. But those three things, sleep, diet, and exercise, are your really big levers for reducing inflammation and improving your metabolic health.
I think that's great. I think that was exactly what we were thinking too, is, you just said it, sleep, stress, all these other, that all plays a big role into it. And that also makes sense with the inflammation discussion, why some people will go on these fad diets that are supposed to reduce inflammation. Well, they may not actually be reducing inflammation the way that they're being sold the diet, but they're probably losing weight in some way, and then they're feeling better because you're the adipose toxicity, all the things you're talking about, the visceral fat, well, you're probably reducing some of that, and guess what? You are reducing some inflammation that way, but it may not be the way that you're being maybe when you're purchasing that supplement or that
Sure.
health trend or something like that.
Okay.
Yeah. So I think we touched on cholesterol numbers and things like that. Kind of just really wrapping up this whole portion of it, would kind of want to say prevention that actually works. So, for us, we talk about things like our listeners might be surprised to know that regular physical activity does reduce that cardiovascular mortality by 30 to 40%. Even a 5 to 10% weight loss improves insulin sensitivity and lipid levels. So on that note, us getting more practical, what are the evidence-based lifestyle changes that actually move the needle for heart health? Like what goals can we say a patient should be doing? A lot of times I think physicians or providers make a mistake in that by saying you just need to exercise more. Well, unless we are giving them quantitative numbers, I think, and metrics and goals to use,
Right.
it doesn't feel like something that's achievable.
Right. Let's see where to start. This CKM access or cardiometabolic health concept is what is evidence-based to reduce cardiovascular risk. So if you normalize your metabolic health, you will reduce your cardiovascular risk probably nearly as much as is humanly possible without medication. There are outliers, so there may be things like autoimmune disease or other inherited disorders that contribute to risk that can't be modifiable with lifestyle. But of the things we can modify with lifestyle, if you normalize those 5 numbers, right? Blood pressure, waist circumference, triglycerides, HDL, and blood sugar, then you're winning, right? We're doing everything that we can do to keep you a healthy human. I think the thing that overlaps a lot is people expect that if they lose weight, if they change their diet, that their LDL will become perfect, and that is not true. And so I think that overlaps, because when we say lipids will improve or cholesterol will improve, we mean triglycerides and HDL, because those are directly reflective of your metabolic health. LDL moves a little, and in some people, a good bit, but a lot of the time, if it's a legitimate risk factor to begin with, or you have family history that makes us want to optimize that number, then lifestyle probably will not move the needle enough to optimize it. What is optimum is a whole other detailed conversation, but it is lower than most people think, especially if we're talking, I don't want to make plaque that's going to accumulate in a way that might be my cause of death.
Yeah.
It's got to be pretty low. So that is separate. Remember, we had our atherogenic lipoprotein column and we have our inflammation column, and all of the inflammation column is lifestyle. So the evidence-based lifestyle changes that we can make to help cardiovascular risk are the same changes that we make to improve cardiometabolic health or metabolic health. They're the same thing.
I like giving the 5. I
one
think that's
diet
really
for
helpful.
each.
Yeah. One diet for each. We sit here, and it's been funny interviewing so many different physicians in different specialties. It all comes back to very similar diets that are beneficial all across the board. It's very Mediterranean diet, the DASH diet, things that, are lower in carbohydrates and saturated fats and all of those things, it feels like.
Yeah. The data is pretty consistent. And, whether you're looking at kidney disease or heart disease or dementia or diabetes or, we know what is a healthy pattern, and it doesn't have to look exactly the same for everybody. It won't, but we know what's healthy.
Yeah, I haven't seen many physicians come on here and support saying like, oh, the carnivore diet's what you need to become a healthy heart and stuff. So, yeah.
Well, and we've talked about this in previous episodes too. We have such good data on statins. I know there's a lot of negative out there about it. I think that's a lot of misinformation too. And I think everybody's going to have terrible side effects and it's just miserable and everything else. But the data for it, for what it can do, is great. I know you can touch on that, but the other one too that I'm real interested in is, has GLPs made its way into any preventative strategies yet in the cardiovascular world? I know it's kind of up and coming in every specialty right now.
Absolutely. I think so. Several GLP-1 and GIP drugs have indications for cardiovascular risk reduction. And that the way that we obtain those drugs or have insurance cover them is in patients who already have cardiovascular disease or metabolic disease. So I can't say that it's really from a primary prevention standpoint unless we're able to get the drug approved for weight loss alone, because all those other indications tell us that there's already something wrong. We have a disease process, whether it's blood sugar related or cardiovascular disease related, or sleep apnea is another diagnosis. And so I would say it has a place, certainly. It's not yet labeled for primary prevention in that sense, but it already has labels for secondary prevention in those patients at higher risk.
What would be your one line if you could say for statins when people come back and they say, oh, it causes dementia, kills your liver, or you're going to have symptoms like, oh, they say not even just like muscle pain. They're going to be like, you're going to have muscle atrophy. What do you say back? What is a good line for clinicians or somebody who's curious?
Miss.
There you go. I mean, there's so much data about it. Mm-hmm.
As far as one line, I don't know, one line is hard, but I could give you a line for each. It's really a story. I can't do it in one line.
We just know the data's there. And we've had other cardiologists go through it, but it just a good reminder is to be careful with what is on social media, specifically about statins and even the GLP-1s.
What we talked about with the black and white interpretation of what's on social media is what gets us into a lot of trouble, because I think the statins will give you muscle aches is the most classic example. Mm-hmm. I don't think the general population understands the pharmacokinetics of statins.
Right.
Probably not. Right. Okay.
No.
So each of our 9 statins on the market has, or the most commonly used ones, has a different way that it's processed. It goes in one door and out the other in the liver, and it has different water and fat solubility. It has a different half-life. So there's a lot that make each statin different. And each patient won't respond to each statin in the same way. So they're not all the same. The other thing is that I think what contributes to this misinformation about myalgias or muscle aches with statins is that what is sensationalized is what happens in patients who have events. So they have a heart attack or a stroke and they get put on a statin. And all of our studies were designed so that when you have an event, we give you the big guns, right? So they get put on atorvastatin 80 or rosuvastatin 40. Mm-hmm. Atorva 80 is what's in most of our major adverse cardiac event studies. And so that'll give anybody muscle aches. Okay, so muscle aches are entirely dose dependent. Mm-hmm. And so when patients get put on a high dose and that's their first encounter with a statin, well, number one, we should have been treating this disease decades before to prevent this event. But unfortunately, we've had an event and now we have to try to make up some time. And so we're being more aggressive. And with that comes some side effects sometimes. But most of the time we can find a dose where patients don't have muscle aches. And the nice thing about statins, which is not true about most medications, is that they work the best at the lowest doses. So the starting dose of rosuvastatin, which is 10, or the starting dose of atorvastatin, which is 20, is where we inhibit the HMG-CoA reductase enzyme the most. Mm-hmm. And then each doubling of the dose after that gives diminishing returns in terms of lipid lowering and exponentially higher side effects. And so in the field of lipidology and cardiovascular health, I think that there's been a more recent movement with data to support moving to a non-statin therapy at a lower dose, like maxing out your statin at a lower dose in order to help maintain quality of life while improving risk reduction. So go have the conversation with somebody who knows what they're talking about, because there's a lot more to it than yes, no, muscle aches, no muscle aches, statin, no statin. So just that's how I would leave it.
That's a good summary. That's a good summary. Mm-hmm. Yeah. And I think, overall, what this conversation is really summarized for us is there's a lot of daily things that we can do. Some things we can't, modify. And that's why we have physicians. That's why we have medicine and healthcare. And that's what helps us live long. But that definitely doesn't overshadow the things we can do for ourselves daily for our heart health. And I think that's a really good reminder that we have medications and we have interventions, but a lot of it is on us as the patients as well. We are patients too. We're not just doctors. We are our own patient. And we know this and take this seriously, that it's daily choices.
Exactly. Yeah. Prevention starts early, touches everything from nutrition and stress to sleep and movement. So I think that this is great. I like the 5 things. I always like giving patients something that they can look at and think, okay, I can't do everything, but I could do something on there. So if we can give them, the 5 modifiable things, that's great as well.
Mm-hmm. Absolutely. Well, thank you so much for joining us today and for helping us separate facts from the fiction when it comes to heart health and prevention.
Thanks for having me, ladies.
Don't forget, if you're a listener claiming your CME credit, check the show notes for details.
And please like, subscribe, and follow us on Instagram and TikTok at the MedEdit Podcast.
Thank you for listening to the MedEdit Podcast. Please click the follow button to be notified when more episodes become available. For more information about this episode and to find out how you can reach Dr. Carrie Sorrell and Dr. Jessica Gray, please visit today's show notes. Be sure to follow us on our socials, Facebook, Instagram, and TikTok to stay up to date on all things the Med Edit podcast. The information and content has been made available for informational and educational purposes only and does not constitute a physician-patient relationship. If you need medical advice or help, please contact your personal physician. The views and opinions of the guests do not necessarily reflect the views of Dr. Jessica Gray or Dr. Carrie Sorrell. This podcast should not be considered an alternative to medical advice or diagnosis or confirmation of an illness or disease. Please seek help from your personal care practitioner. Thank you for listening, and tune in next time.